Good afternoon, everybody, and welcome to the webinar. Today, I'm so excited because we're starting a new series on hypertrophic cardiomyopathy, or HCM. But today, we are going to learn the basics about HCM, what cardiomyopathy is, and why we should know about it. So we're going to get started today. While everybody is joining on, I just want to give everybody a couple of notes before we start. If you want to move to the next slide, we will have just a couple of things to make your experience a little bit better here. First, all attendees are in listen only mode. If you can't hear, hopefully you can see the slide. Check the audio button on your personal computer to make sure that your audio is turned on. That's typically the issue. And please type all of your questions into the Q&A box, because we will get to questions at the end of the presentation and I'll read the questions out. We will have a version of the slides and a recording of the presentation that will be available following the event. And we will have a handout as well available on the website. One thing to note, Dr. Saberi, who is with us today, cannot answer specific questions about your care because she's not your treating physician. I'm going to go to the next slide. And just in case you don't know who Mended Hearts is, we are a national organization, an international organization now, whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. And now I want to introduce to you Dr. Saberi. She is the Assistant Clinical Professor in the Division of Cardiovascular Medicine, co-director of the Inherited Cardiomyopathy Program at the University of Michigan. And I am going to let her do all the talking now. And thank you for being here with us today.
It's completely my pleasure. Thank you so much for having me. So I actually decided, since I thought this would be a fairly broad audience of people interested in cardiomyopathies in general, not just to focus on hypertrophic cardiomyopathy in this kind of introduction webinar, but go a little bit broader out into the cardiomyopathies in general and kind of talk about the inherited cardiomyopathies as a whole, with hypertrophic cardiomyopathy being a subset of them. So cardiomyopathies, that word really just breaks down into cardio being heart, myo meaning muscle, and pathy meaning disease. So it's literally heart muscle disorders is what a cardiomyopathy means. So it's a big bucket and refers to a large number of disease processes that can affect the heart muscle. I have here a slide that shows kind of a graphic of what the different inherited cardiomyopathies can look like. So all the way on the left is what we consider the normal structure of the heart, which is the top chambers being the atria, the bottom chambers being the ventricles. In this picture, the left side of the heart is actually on the right side of your screen. And you can see that the way that blood flows is from the lungs into the left atrium, down through this doorway, the mitral valve, into the left ventricle. And then the left ventricle, when it squeezes, it pushes blood through this doorway called the aortic valve into the aorta. The aorta and its branches carry that oxygenated blood all throughout the body. The organs use what they need of it in terms of oxygen and nutrients to do their work. They dump their waste products back into the bloodstream, and that blood comes back up the venous side after it's cleaned through the liver and the kidneys into the right side of the heart, and the right side just pumps through the pulmonary artery to the lungs, and the lungs reoxygenate the blood, and the whole cycle starts over again. There's a normal relationship of these four chambers. You know, there should be four, and the top chambers should be smaller than the bottom chambers. The bottom chambers should be much more muscular, this layer representing the muscle thickness, as opposed to this little thin layer of the atrium being the muscle thickness. The left ventricle, since it pumps to the entire body, should be a bigger kind of in diameter and volume chamber and more muscular than any of the other chambers. In hypertrophic cardiomyopathy, we actually see that the left ventricle becomes thicker, not necessarily bigger, meaning that the chamber size itself, the space where blood comes into, is not bigger, but it is thicker. So it's a heart muscle disorder where the ventricle becomes, the left ventricle is thicker. Dilated cardiomyopathy is the opposite of that, where the inside of the chamber, the cavity space where blood can come into, becomes dilated or bigger. And oftentimes that is accompanied by a thinning of the myocardium. You can see that the thickness here is significantly less than what it is in hypertrophic cardiomyopathy and less than what it is in the normal heart. Then there's another class within dilated cardiomyopathy called left ventricular non-compaction cardiomyopathy. And this is a little bit more unusual of a disease where you actually see this kind of spongy formation at the tip where you have these kind of recesses that jut into the muscle and create this, sponge-like looking tip of the heart. That's often also accompanied by dilation, kind of widening of the chamber, increased volumes, amount of blood that's held in there, and then a dysfunction in the pump. And finally, there's arrhythmogenic cardiomyopathy. And this is another disease process that involves both the heart muscle and the electrical conduction system of the heart. It was formerly thought to primarily involve the right ventricle and less so the left, but over the last 20 years, we've really learned that it involves both ventricles, though you can still see a predominant right-sided kind of presentation with the right ventricle. The right side becomes very big and dysfunctional. The age of diagnosis of these diseases is highly variable, so not everybody's going to present when they're young, even though these are genetic heart muscle disorders. They're all associated with heart muscle changes, whether it's thickening or thinning or dilation. All of the problems really stem from an issue within the heart muscle cell itself. They can cause rhythm abnormalities, in most cases are genetic. So this is just a graphic that kind of displays what the genetic inheritance of most of the cardiomyopathies are. In this side, you can see a display of what we call autosomal dominant pattern of inheritance, where basically there is an abnormal change in the DNA for the cardiomyopathy that's present in one of the two copies of a gene. So in our bodies and our DNA, we have two copies of every single gene, one that we inherit from our mother and the other that we inherit from our father. And so when there's a disease process like this, then there'll be a change on one of those two copies. And each of the children then has a 50-50 chance of inheriting that abnormal gene, because they're going to get one of these two from dad and one of these two from mom. So the two from mom in this case are normal. So that isn't going to cause a problem, but then the child that inherits this particular allele from the father is going to potentially have a disease process. So that 50-50 transmission is what we term as autosomal dominant, as opposed to, disease processes where the abnormal gene may be on the X or the Y chromosome, so men and women are differentially affected, or it's a recessive process, which becomes even more rare. Most of the cardiomyopathies that we're talking about today have a 50-50 chance of being passed from parent to child, but having this pathogenic variant, kind of disease-causing variant, does not equal developing the disease. So there's a lot that goes on that we don't understand that has to happen from just carrying the genetic change to actually expressing the disease itself. And when we do genetic testing in patients who we see evidence of disease in, we can usually identify the genetic cause in about half of the patients with a cardiomyopathy. So there are another half who clearly have a disease process that we can visually pick up on imaging or a clinical presentation, for whom we've not been able to identify a genetic cause. That doesn't mean there's not a genetic cause. It really just shows you where we are in the science of genetics, and really probably are in its infancy, as these genetic underpinnings of the cardiomyopathies really have only been identified since the mid-1980s. When we do genetic testing currently for these different disease processes, we have about a 50 to 70% chance of actually being able to identify the variant in patients who have hypertrophic cardiomyopathy, about a 40 to 50% chance of identifying that genetic variant in people with dilated cardiomyopathy, and then it drops off with left ventricular non-compaction to about 20 to 30% chance of having a positive genetic test result when we do the testing. It's about 50% for arrhythmogenic cardiomyopathies. So in hypertrophic cardiomyopathy, like I said before, we have heart muscle thickening, or also called hypertrophy. There's stiffening and scar tissue formation that leads to abnormal relaxation properties of the heart muscle. The squeeze force of the left ventricle is normal or greater than normal. So oftentimes it's not a pumping problem that is the issue, but it's really the relaxation of the heart muscle that's abnormal in hypertrophic cardiomyopathy. Most often the pumping function is supernormal, and that in and of itself can lead to kind of an obstruction to blood flow out of the heart. Where the heart muscle is thick, blood has to come out of this canal into the aorta, and if that muscle is thick here, it'll narrow this canal, and therefore, you drop a canal that should be the size, of a straw down to a coffee stirrer, and it's a lot harder to push anything through a coffee stirrer than it is through a straw. So you get some obstruction to blood flow out of the heart in that way. About a third of patients with hypertrophic cardiomyopathy will have a significant degree of obstruction to blood flow just at rest. Another third only have significant obstruction when they're doing something exertional, when the heart rate picks up and the demand for work on the heart increases. And then the last third don't have any obstruction to blood flow because the thickening of the muscle doesn't affect that kind of the diameter of that canal. Arrhythmias are common, both atrial and ventricular. So atrial arrhythmias are actually quite common. Atrial fibrillation affects about a third of patients with hypertrophic cardiomyopathy. Ventricular rhythm abnormalities, those that generate from the bottom chambers of the heart, are much more unusual, affecting less than 1% of patients with HCM a year. So they are much more dangerous, and so they're certainly a focus of our clinical care. Heart failure is a nasty set of two words put next to each other that everybody who hears does not like to hear, of course. But when we say heart failure in the medical community, we're really talking about an abnormality in the pump function. And again, whether that's a squeeze dysfunction or a relaxation dysfunction. Like I said before, because of the stiffening of the heart muscle and the scar tissue formation in hypertrophic cardiomyopathy, the heart failure that we see is really one of relaxation property abnormalities. And so people can have symptoms of heart failure, which would be shortness of breath, fluid overload, swelling in the belly, swelling in the feet and ankles, that sort of thing, either at rest, but in particular with activity. And that is a common complication kind of later on in the disease process. It's unusual to see that in the first couple decades of the disease process, but that becomes more prevalent for people in their 40s and 50s. And then the squeeze dysfunction is very unusual, occurs in less than 10% of people with HCM, and tends also to occur much later in the disease process. The disease is really caused by abnormalities within the genes that govern the cardiac sarcomere. The sarcomere is just a fancy word for the motor. So it's a group of proteins within the motor of the heart muscle, and it's usually an abnormality in one of those proteins that causes the disease. It's the most common inherited cardiomyopathy occurring in about 1 in 500 people. So it's actually much more common than we used to think that it was. Dilated cardiomyopathy, I think of as the opposite of hypertrophic cardiomyopathy. So this is a disease process that is also common, not less so than hypertrophic cardiomyopathy, but is thought to occur in about 1 in 2,500 people, though and that's largely thought to be highly underestimated. A lot of what we had thought was related, cardiomyopathies related to pregnancy or related to chemotherapy or alcohol abuse, really we now understand to be inherited cardiomyopathies through genetic testing. And we find that these environmental hits are really what uncover the dysfunction of the heart muscle, but it was a genetic heart muscle condition all along. Dilated cardiomyopathy involves dilation or kind of a ballooning out of the left ventricle, and often, like I said before, that's accompanied by a thinning of the heart muscle walls themselves. It always involves the left ventricle and sometimes can also involve the right ventricle. It uniformly results in abnormalities in the squeeze function of the ventricles and in the relaxation, but the squeeze dysfunction is a more prominent feature. Heart failure is a very common complication. So you can have a dilated cardiomyopathy where the left ventricle squeeze is abnormal but have no symptoms of it. In that case, you don't have congestive heart failure because the definition of congestive heart failure is symptoms related to the heart muscle disorder. So developing congestive heart failure would be symptoms associated with that pump dysfunction. And that is actually a quite common occurrence of dilated cardiomyopathy. It can also involve rhythm abnormalities, again, generating from the top and bottom chambers of the heart. And it's a more complex disease than hypertrophic cardiomyopathy and its genetic underpinnings. It can result from genetic abnormalities in the sarcomere, the motor of the heart muscle, but also in some of the structural components around the motor and in the cell membranes. Left ventricular non-compaction cardiomyopathy is a little bit more unusual of a disease process. It is not known what the prevalence is, how common it is, because it's really been only with the advancement of our imaging technologies that it's really been recognized. We used to not be able to see the heart very well on echo machines and cardiac MRI machines, but really more echo, 30, 40, 50 years ago. And now with the advancement of those technologies, we can see the inside of the heart super well and can pick up abnormalities that we really weren't able to before. And this is one of them. So we see this kind of spongy heart muscle that's predominant over the compact muscle at the mid to the tip of the left ventricle. So the compact muscle really, if you were to do a little biopsy and examine it under a microscope, would look like a really organized brick wall, as opposed to this spongy heart muscle that's really disorganized and disarrayed and does not look like a brick wall at all. It looks more like an amoeba, where there's these kind of little projections of muscle off the wall and down into the chamber of the left ventricle. And those projections are not normally functioning. They don't squeeze normally, they don't relax normally. You can see this in isolation, meaning that you can see some spongy appearing heart muscle at the tip of the left ventricle with no other abnormality of the left ventricle, meaning that it's functioning normally, or you can see it with a dilated cardiomyopathy and sometimes with hypertrophic cardiomyopathy. And most of the genetic changes that we've been able to identify associated with this disease are in the same genes that have been implicated in hypertrophic cardiomyopathy and in dilated cardiomyopathy as well. Rhythm abnormalities and heart failure can occur. And this particular disease process, because of these little recesses that we see within the muscle, is prone to having blood clots form within those recesses. And so there's a higher risk of stroke if those blood clots kind of go flying out of the ventricle and up to the brain. There's a higher risk of stroke associated with left ventricular non-compaction than there is with any of the other cardiomyopathies. And so it's the only of the cardiomyopathies where we would recommend blood thinners just in and of itself for having the disease process if the heart's pump function falls below a certain level. We don't routinely recommend blood thinners for other people that have cardiomyopathies because the risk of stroke is low. And then finally, arrhythmogenic cardiomyopathies, these, like I said before, tend to affect the right ventricle more than the left, but both can be involved. Rhythm abnormalities that generate from the bottom chamber of the heart are more common in arrhythmogenic cardiomyopathies than in any of the other cardiomyopathies, and they're often out of proportion to the degree of dysfunction of the heart muscle. And so there are, for all of these cardiomyopathies, kind of very specific guidelines about what characteristics have to be in place in order for us to deem that the risk of sudden death related to a rhythm abnormality that generates from the bottom chamber of the heart is high, higher than what we would like to see, and so a defibrillator may be recommended. And those risks are more prominent in arrhythmogenic cardiomyopathies. Heart failure can also occur in arrhythmogenic cardiomyopathies, particularly if the left ventricle is involved in the muscle dysfunction. These are disease processes that are often caused by genetic changes in something called the desmosome, which is a structure that connects the heart muscle cell both physically and electrically to its neighbor heart muscle cell. So it's a little different than the other diseases in where the motor itself is involved. There are more unusual diseases that occur in 1 in 2,500 or 1 in 5,000 people. So how might somebody with a cardiomyopathy be diagnosed? Well, many people are actually completely asymptomatic and have no symptoms whatsoever at the time of the disease. And how it's picked up is maybe on physical exam, a murmur is detected, and a murmur is just turbulent blood flow in the heart. So what it means is that when I listen with a stethoscope, I hear not just the lub-dub, that is the heart sounds, but I might hear a lub-whoosh-dub, and that whoosh is the murmur. And all it indicates is turbulent blood flow inside the heart for one reason or another. And there are certain features on exam and kind of features of that murmur and kind of how, what part of the cardiac cycle is loudest, whether or not I can make it louder by doing some particular maneuver that may give me clues about where that turbulent blood flow is coming from. It may be found incidentally, like you come in and are having some, a colonoscopy, and they want to do an EKG before you have your colonoscopy, and you're found to have some abnormality on the EKG, and then that leads to an echo that identifies a structural abnormality in the heart. Or people who are asymptomatic but are undergoing family screening may be diagnosed in that way. And what that means is that there's somebody in the family who has been diagnosed with one of these kinds of disease processes, and other family members have been recommended to undergo clinical screening evaluations to see if they have evidence of disease. And on EKG or echo, there are clues about the disease process in that person as well. It's more unusual to have an acute event be, the trigger for finding this disease process. An acute event, an aborted sudden death or a passing out or an initial presentation of congestive heart failure, though those definitely do occur as well. Symptoms that are related to the cardiomyopathies, all of them have similar symptoms. Those include shortness of breath, most often with activity, and then some people will recognize that over time there's progression such that it takes less and less of a particular type of activity or intensity to bring on that shortness of breath, or that it used to be that I used to have those symptoms just with activity and now I'm noticing them at rest or if I'm laying back I find that I'm uncomfortable in my breathing. I have to prop myself up on pillows, that sort of thing. It can be chest pain, pressure, heaviness, either with activity or at rest. It can be lightheadedness, syncope, meaning passing out. It could be just fatigue and overall sense of dragging and not having energy to do the things that other people would have no problem with. And it could also be palpitations, kind of a fluttering sensation in your chest. How the cardiomyopathies are diagnosed really depend on imaging. So certainly EKGs can show us some abnormalities, but EKG abnormalities for the cardiomyopathies are very rarely specific, meaning like that there are specific findings on the EKG that seal the deal. All of the cardiomyopathies are diagnosed with imaging, either by echocardiography or by cardiac MRI. So an echocardiogram would just be an ultrasound of the heart. So it's kind of a probe and some gel, cold or warm, depending on where you're getting your study done and how good they are that day. That goes up on your chest, and then an ultrasound is done that takes a look at the heart chambers and the valves, the doorways in between. A cardiac MRI is a scanner, and you lay on a bed and you're kind of moved into this donut, and they'll be able to do pretty high resolution images of the heart muscle. At an echocardiogram should take no more than about 30 to 40 minutes to do a good complete study. Sometimes a little longer if an abnormality is detected and you're going to do additional imaging really focused on specific abnormalities. A cardiac MRI would take about an hour. It will often involve getting an IV placed and contrast agent being administered to take a good look for evidence of scar formation or fibrosis. We're not able to see scar very well on echo. Sometimes we can, but in these disease processes, the type of scarring that happens is very hard for us to detect on echo. But that's the type of thing that we can pick up on cardiac MRI. Cardiac MRI is really the gold standard for defining the squeeze function of the heart. We can do that with echo as well, but cardiac MRI is the gold standard because it has such high resolution imaging. We're able to measure the volumes of the ventricles and really do the calculations more accurately than we can on echo. But it's not as good of an assessment of the valves as an echo is. So a lot of times patients with these cardiomyopathies are routinely evaluated by echo, and then once in a while, they may get a cardiac MRI for a more kind of intense and thorough evaluation if it's going to make a difference in their overall clinical care. The goals of treatment for all the cardiomyopathies are the same. First of all, to treat symptoms and improve quality of life. Secondly, to prevent the condition from progressing. And then lastly, to prevent sudden death and prevent hospitalizations related to rhythm abnormalities or congestive heart failure. And this is all done similarly for these cardiomyopathies. Medications, of course, first and foremost. Surgery could be recommended, especially for hypertrophic obstructive cardiomyopathy, where we may be able to do surgeries to relieve that obstruction to blood flow. And then for those who have very advanced disease where there's really lack of response to medications, no surgery can fix what's going on, then it may include things like recommending a heart transplantation. Internal defibrillators may be recommended, and some, again, dependent on how risky the situation is thought to be in terms of developing rhythm abnormalities that could be life-threatening. So a defibrillator's job is really to act like a very personalized life insurance policy. Its job is not to do much of anything else. Its job is really to recognize those rhythm abnormalities and either pace or shock people out of those rhythm abnormalities and save their lives. What I think every patient with a cardiomyopathy should ask their physicians and know themselves in order to be able to understand, what the disease process is, where they are in the kind of natural history of the disease process, and what their treatment options are. First and foremost includes, what is my ejection fraction? So the word ejection fraction really is the term that we give to how efficiently the left ventricle is squeezing, pumping. And so it's kind of an assessment of, of the amount of blood that comes into the left ventricle during its filling phase, how much of that then is squeezed or ejected out. And a normal ejection fraction is 55 to 70%. Anything under that is abnormal. Anything above that is abnormal. So above 70%, 70% and above is really considered hyperdynamic or a very hypervigorous pumping function. And that's often what we see with hypertrophic cardiomyopathy. And ejection fractions less than 55% are low. And they fall into different categories. So mildly dysfunctional, moderately, and severely dysfunctional. People may have no symptoms in the mild to moderate dysfunctional category, but it's unusual to have no symptoms in the severe left ventricular systolic dysfunction category. An ejection fraction under 30% is considered severe LV, left ventricular systolic dysfunction. The moderate category is 30 to 40%, 40 to 55 is considered mild squeeze dysfunction. So you should know what your ejection fraction is if you have a cardiomyopathy. And different medication treatments may be available to you dependent on what that ejection fraction is, because studies, clinical trials have been done in patients with kind of different ejection fraction categories, and some medications have been shown to be effective only in the most severely dysfunctional kind of categories as opposed to milder. And so knowing what your ejection fraction is important, because that also helps guide, what the treatment options are as well. For those that have a low ejection fraction, being able to ask whether or not you're on all the medications that have been shown to improve ejection fraction is important. Certainly that improvement in ejection fraction has been correlated with living longer and having fewer heart failure hospitalizations. And so being on medications to try to improve the ejection fraction as close to normal as possible is important. There are really four main classes of medications that are recommended for treating heart failure with reduced ejection fraction. And knowing whether or not you're on these four classes of medications and why you are not, if you're not, is important. And being able to ask your doctor those questions should be part of your day-to-day conversations. For people that have hypertrophic cardiomyopathy, knowing whether or not you have obstruction to blood flow inside the left ventricle is important. And again, because that changes what treatment options are offered to you, and whether or not surgical or other invasive options are also offered to you. So there's no surgery or alcohol septal ablation or kind of any other invasive procedure that's ever been shown to be effective in improving symptoms or prolonging life in patients that have non-obstructive HCM. And so, knowing whether or not you have obstruction is important. That cutoff between obstructive and non-obstructive is a 30 millimeter of mercury difference between inside the heart and out, meaning like if your blood pressure is checked in your arm and your systolic or the top number blood pressure is 120, it should be less than 30 millimeters of mercury higher than that inside your heart, so less than 150. And if it's more than that, then you have obstructive HCM. And if it's significantly more than that, 50 millimeters of mercury, either at rest or with activity, then there may be other options that are offered to you. And then the last thing that I think is important to ask your doctor and talk about is whether or not you should be on blood thinners, especially if you have atrial fibrillation. So there are very, very few instances in which someone would have a cardiomyopathy and atrial fibrillation and not be recommended to have blood thinners. And we should be looking for atrial fibrillation because it's such a risk factor for strokes in all of our patients. So if no one's ever talked to you about atrial fibrillation or said, I think we should look for it, that's an issue. And you should be thinking about that and asking about it. If you have a lot of palpitations, kind of fluttering sensation in your chest, you should bring that to your doctor's attention so that they can be looking for it. And the looking for it would really be a monitor that's placed on your chest for a period of time. And that kind of period of time is chosen based on how frequently you're experiencing it. It might be 24 hours, it might be 48 hours, it might be a few days, up to a month. But then the two of you can decide together what makes sense in that regard. So the genetic basis of inherited cardiomyopathies is now largely known through the work that's been done since the early 80s. Genetic testing combined with a clinical evaluation can be used to identify the inheritance pattern of these cardiomyopathies and the risk that may be there for other family members and help guide who should be screened and how often the screening should be, whether or not that screening should be genetic or clinical. All of those recommendations you should be able to talk with your doctor about. And there's been a lot of movement in this arena in the last 30, 40 years for every single one of these cardiomyopathies. The science is changing quickly as there's a lot of interest in understanding the mechanistic, underpinnings of the disease process, which then help to guide the treatments being developed and the treatment options out there. And the inherited cardiomyopathies are really poised for major scientific advancement. And there's a lot of movement towards even things like gene therapy, which really is in its infancy right now, but exciting to think about as an option in the next couple of decades for people with inherited cardiomyopathies. And that's really my entire presentation. I left it kind of broad so that people would have an understanding of all of them as a whole. And I'm happy to talk about more specifics if anybody has more specific questions.
Great, thank you so much. Lots of really good information. And it was great to break down the differences between the cardiomyopathies to start with. So that was great. I do have one question already in the queue, and then I have another question that was posed to me to ask today. And so I'm just going to get started. If anybody else has questions, please type them into the Q&A box and we will get them answered as best we can. So the first question is, could you tell us what the 4 classes of medications to be on are?
Sure. So the 4 classes of medications that are used to treat people that have cardiomyopathies where the left ventricle squeeze function is reduced are number 1, beta blockers. So medications like metoprolol, bisoprolol, carvedilol are the 3 in particular that have been shown to be effective. The second class are ACE inhibitors, angiotensin receptor blockers, and ARNIs. So these 3 are kind of clumped together. And really, it's really mostly now Entresto. So Entresto falls into a class called ARNIs. It's a combination of valsartan, which is an ARB, an angiotensin receptor blocker, and another medication called methylprine. And if somebody can't tolerate Entresto because of blood pressure or side effects, then we would kind of ramp down to ACE inhibitors, which would be things like lisinopril, enalapril, captopril, or its cousins, the ARBs, which would be like losartan, valsartan, irbesartan, the TAN medications. That's the second class. The third class of medications are mineralocorticoid receptor antagonists. So spironolactone or aldactone really is the only medication in that class that's currently available in the United States. And then the last one being the most recent, which is the SGLT2 inhibitors. So medications like empagliflozin or dapagliflozin, which were actually medications. So you may recognize them as Jardiance or Farxiga from TV commercials. And these are medications that were originally developed for treatment of diabetes, but in the clinical trials, were found to actually be highly effective amongst people that have congestive heart failure and reducing heart failure hospitalizations. So that led to specific clinical trials amongst people that have congestive heart failure, both with reduced ejection fraction and with preserved ejection fraction that have been, and in both groups, they have been shown to improve mortality. So people live longer on the medication when they have heart failure and reduce heart failure hospitalizations.
Great, thank you.
Mm-hmm.
Okay, so the next question is, genetically speaking, if one parent has an arrhythmogenic cardiomyopathy, could a child develop HCM, or is it type specific?
There are some that are type specific. So arrhythmogenic cardiomyopathy is type specific, meaning like if a parent has arrhythmogenic cardiomyopathy, the only way the child would be able to have hypertrophic cardiomyopathy is if they inherit a genetic abnormality that's specific to hypertrophic cardiomyopathy from the other parent, or if in their conception that there was an error in the printing of that DNA such that they now have a sarcomere mutation or a sarcomere change that leads to the disease process of hypertrophic cardiomyopathy. With hypertrophic cardiomyopathy and dilated cardiomyopathy and left ventricular non-compaction, because those diseases are all diseases of the sarcomere for the most part, there can be an overlap, meaning that there are definitely, we see patients who in their families, there may be some people that have a dilated cardiomyopathy and others that have hypertrophic cardiomyopathy. It's unusual. I would say fewer than kind of 5% of my patients have family histories like that. But those ones there, because it involves the sarcomere, there is some overlap between those disease processes between family members.
Okay, great. And then if you could repeat the third piece of the medication. I think she's trying to take notes, and she said that very fast.
Sorry.
Okay.
Yeah, the mineralocorticoid receptor antagonists, and the medication specifically would be spironolactone or aldactone. That's the third class.
Okay, great. Thank you. So can you give any information on you have on the new medication for obstructive hypertrophic cardiomyopathy, and why is it so specifically for obstructive?
Sure. So these are medications that fall into a class called cardiac myosin inhibitors, and they have been developed out of actually the original work that was done in identifying the genetic underpinnings of hypertrophic cardiomyopathy. So in understanding what the genetic abnormalities are, then we were able to identify the abnormalities in the proteins, and often the proteins within the sarcomere, what you have are a protein that acts like a gas pedal and one that acts like a brake pedal. And in HCM, what's happening is that the genetic change results in too much gas, either because it's a change in the gas pedal itself or a change in the brake pedal such that the brake isn't on enough. And there has to just be a nice balance between the gas and the brake in order for this squeeze and relaxation function to happen in a normal way. So myosin inhibitors were developed because of a recognition that there's too much gas. And the medication basically binds to the myosin head, myosin being the gas pedal, and it forces some of them into a more relaxed phase such that they're not interacting with the other proteins and causing this hypervigorous squeeze. And so the first medication in this class that has come out is called mavacamten. Its trade name is Camzyos, and so you may see, commercials about it or advertisements about Camzyos. And the trials that have been performed looking at efficacy of this drug have only been in patients with obstructive hypertrophic cardiomyopathy. There has been a phase 2, meaning feasibility and safety clinical trial of mavacamten in patients with non-obstructive hypertrophic cardiomyopathy, but the phase 3 trial that's aimed at efficacy, is this medication helpful for patients with non-obstructive HCM? That trial has not yet even been started, though though it will get going in this next year. So the reason it's only approved by the FDA for patients with obstructive HCM is because that's the only patient group for which there's data present that shows that it is helpful. And what it does is because it reduces the vigor with which the heart squeezes, it just creates a little bit more filling time and reduces the amount of obstruction to blood flow and all the symptoms that are related to obstruction of the heart. So, you know, chest pain, shortness of breath, lightheadedness. It reduces some of the strain within the heart muscle, kind of markers of strain that we've seen. It increases the exercise capacity that patients with HCM have. They're able to do more for a longer period of time. And there's some preliminary data that is suggestive that the medications can actually kind of have a positive effect on the remodeling of the ventricle. So meaning that it reduces the heart mass, reduces thickness of the muscle, and without actually harming the overall squeeze function. The ding for these medications as a class is that, you know, the way that they work is by reducing the vigor with which the heart muscle squeezes. And so that can go too much in the opposite direction and cause a pump dysfunction as well. In the clinical trials, that's really only occurred in about 5-7% of the trial participants. And they've been under kind of pretty specific situations. And when you take the drug away, the pump function returns back to normal. So there, you know, the FDA approved it at the end of April. It's really only kind of starting to be prescribed in the last month or so as the drug has become available. And there will be a large national registry, safety registry of patients with obstructive hypertrophic cardiomyopathy that either are getting mavacamten or not getting it at all, but getting other treatment, to look to see in kind of a real world population, how do these drugs fly in terms of, you know, safety for patients.
Great, thank you.
Sure.
So is mitral valve regurgitation considered a cardiomyopathy?
No, that's a valve problem. So a cardiomyopathy is, it has to be a muscle disorder.
Okay, okay. And then mavacamten is MAVACAMTEN.
Correct.
That's how to spell it, which is great. Okay, so if a child with HCM has been diagnosed with an echo, no MRI yet, is it definite they have the disorder, or is it maybe not? They also state that there's genetic testing that's been done that states the genes identified are a variant of the genes that are identified as HCM, but they're still doing more testing. So if you have the gene, does that mean you have HCM?
An echocardiogram is the mainstay for diagnosing any of the cardiomyopathies. Cardiac MRI, so almost all of them are diagnosed by echocardiogram because they're cheaper, they're readily available, they don't, you know, involve like a lot of special expertise in terms of either doing it or reading them. I mean, it does, but not quite the same way that cardiac MRIs do. And so you can absolutely a child can be diagnosed with HCM just based on echo alone. If the diagnosis is kind of in question, then a cardiac MRI can be helpful in pushing you one direction or the other for sure. So, but you don't need to have a cardiac MRI in order to be able to make the diagnosis. And then in terms of genetic testing, so there are three things that can come out of a genetic test result. One is that we find a likely pathogenic or definitely pathogenic variant, meaning this is a change in a gene that has been shown up and down, left and right in the literature to actually be linked to disease. And so that's it, it's done. We know that this is an abnormal gene that has a propensity to causing disease. The second option is that the genetic testing reveals no abnormal variants, meaning that it's negative, that everything looks normal on that genetic testing. And then there's an in-between category, which is a variant of uncertain clinical significance, meaning that there are abnormalities in whatever gene that is that we're not sure if they're disease causing or not. And how I like to think about this is all of us on this call have noses, and our noses are different in their breadth, different in their size. Mine has a bump in the middle of it, yours might not. But they're all noses that are kind of just individual to each one of us. And so there are slight variations in the genes for the nose between all of us, such that we each have an individual and unique nose. If I had a big purple ball hanging at the end of my nose, and we did genetic testing amongst us, and I was found to have X change in this one gene for nose, then we can say, okay, that genetic change was found and she has pathology, disease. And so the likelihood that those two things are linked is higher. In order for us to say that something is disease causing, you have to have 5 different people segregate, meaning that 5 different individuals with disease have to have that same genetic change in order for the scientific community to say that that's a disease causing variant. So that's kind of how that works. So if there is not that kind of data behind that particular variant, where we can say, okay, this is a little different, its coding is different than what we see in a normal general population, but we don't have enough data to say for sure whether this is disease causing or not, then the lab will call it a variant of unclear significance. They'll do some statistical modeling to see, okay, a protein that's made from this code, how would that look and how would it function? If that protein is, let's say, or that particular kind of part of the code for the protein is preserved across species. It's the same code for a mouse, for an elephant, for humans, and for monkeys, and it's abnormal, then we know that that particular code is very important because it is the same across all these different species. And so an abnormality in a code that is the same across species kind of raises the bar and says, okay, well, maybe this would be a little bit more suspicious for being disease causing, even if we don't have other data to support it. Or they'll do modeling and say, okay, the protein that's formed from this code abnormality folds left instead of folding right. But if it folds left, it still makes these connections. It can still function normally. We don't think that would be disease causing. You know, so there's just all these nuances to the genetic testing and understanding kind of what the genetic test result means in terms of the protein function and malfunction that feeds into telling you whether or not that change could be a problem or not. So, and then you touch on, does a genetic abnormality equal you will get disease? And the answer is no. So you can have a genetic abnormality in these disease processes in particular and never develop disease. Or you could have the genetic abnormality and develop very severe disease at a very young age, or develop very mild disease at a much older age. And that kind of variability we see across all of these disease processes. So what that tells you is that the genetic change in and of itself is not enough in everyone to cause the disease. And sometimes there has to be something environmentally that interacts with us as humans and our kind of genetic coding that then makes it such that, you know, in a big family, several family members of whom carry the same genetic change, we'll see some people that carry the change their whole life. We do all kinds of screening up and down, left and right for decades and decades and don't find anything, versus, you know, infants that have it, you know, 6-year-olds that develop it, you know, so this kind of high variability has a lot to do with environmental factors that we just don't really know. We don't understand those things well. And interplays with other genetic changes and protein changes that we're really just starting to try to kind of unravel and understand.
Okay, great. So not everybody that has a cardiomyopathy has the genetic component, or yes, they do?
Not everyone that has a cardiomyopathy will have a genetic component, but I think that what we have seen over the last, you know, 40 years is a wide improvement, a large improvement in our understanding of the genetics. And so, you know, genetic testing that was done 20 years ago in someone who clearly had disease and would be negative, we repeat now because the panels are different now, because we've uncovered all these other, you know, proteins that are involved and all these other genetic changes that could happen, you know, in that time. And so I hesitate to say that there are not genetic underpinnings, because that world is changing rapidly as we discover and understand, you know, as we discover more and understand more, the genetic test panels change, the number of genes we look at, the specific genes we look for. You know, it used to just be 8 genes that we would look for back when the first commercial kits came out, and now it's like 30 something, you know, and then it can be like 70 something depending on the panel that you choose. So it really reflects that we are still learning a lot.
Okay, great. Final question of the day.
Yeah.
If you or somebody in your family has a cardiomyopathy, should everybody be tested, genetically tested, to find out if they carry the gene? And is that protocol for everybody to be tested?
So the person who has the cardiomyopathy should be tested, or genetically tested, to see, can we uncover the genetic underpinnings of this disease process in that person. And then whether other family members are tested completely depends on whether or not the patient, the person who has the cardiomyopathy, whether their genetic testing reveals something that's useful or not. So if the genetic testing in the person who has the cardiomyopathy is negative, there's no point to doing genetic testing in anybody else, because we don't even know what we're looking for. So we wouldn't offer genetic testing to any other family members if the person with the cardiomyopathy, if we can't identify it in that person. If we can identify it in that person, this is a clear disease-causing genetic change, then other family members who wish to undergo targeted testing just for that one genetic change can do so to see, do I carry this, and am I at risk for developing this disease? For those who have variants of unclear clinical significance, here at U of M, our practice pattern is that we will only offer genetic testing for that variant in family members where we do clinical screening, echoes, EKGs, physical exams, and an abnormality is picked up there. We do it for 2 reasons. One, first and foremost, to be able to understand more about that genetic change. So if we're able to do testing in another family member who seems to be affected, and that person also carries that variant, now we're building a case that this variant may actually be disease causing. But if that person has evidence of a disease and doesn't carry that variant, okay, that muddies the picture. We clearly don't know what this variant means and whether or not it's really informative. And so we individualize testing like that, and testing recommendations, genetic testing recommendations like that.
Okay, that makes a lot of sense. Just as a follow-up to that, if the person who had HCM passed away from like sudden cardiac arrest,
yeah,
should parents and other siblings be tested? And would they do genetic or just echo?
So if there's a blood spot that was kept by the medical, so if the person who passed away underwent an autopsy, then the medical examiner should have kept a blood spot. If the blood spot was kept, then we would recommend doing genetic testing on that blood spot first, before we would do genetic testing in any other family members. We would tell all the first degree family members of the person who passed away to undergo clinical screening exam, echo, EKG, good cardiac exam. If one of them is found to have disease, then we would do genetic testing in that person. If there's no blood spot, but there is an affected family member, then we would start with the affected family member, because we have to be able to link disease to like this variant, like what I've been saying. And so we would really only recommend clinical screening evaluation uniformly for first degree family members of the person that died. And then genetic testing really just depends on what we find.
Great. Well, we are out of time. So thank you so much. The hour went by so quick. We really appreciate you taking the time to talk with us. For everybody listening, our next webinar in the series is treatment options for hypertrophic cardiomyopathy. It will be next Tuesday, September 27th at 3 o'clock Eastern time. And I hope you all come back and learn some more. So thank you and have a great day.
You're welcome. Thank you so much for the honor of spending this hour with you. Take care.
Thank you. Bye-bye.